Hello everyone, welcome to my Medication Academy channel. In the second quarter of 2025, the US FDA approved 9 novel chemical entity drugs with indications ranging from oncology, proteinuria, generalized myasthenia gravis, dry eye disease, preventing RSV low respiratory tract disease, to preventing attacks of hereditary angioedema. Chemically, 4 are injectable monoclonal antibodies, 2 are oral small molecule drugs, 1 is a combination of small molecule oral targeted therapy for treating low-grade serous ovarian cancer, 1 is an RV injectable antibody drug conjugate for the treatment of non-small cell lung cancer, and 1 is a small molecule topical agent for the treatment of dry eye disease. Now, let's dive into each medication in more detail. Atrasentan, brand name VANRAFIA. This medication was approved by the US FDA on April 3, 2025. And indicated to reduce proteinuria in adults with primary immunoglobulin A nephropathy IgAN at risk of rapid disease progression, generally a urine protein-to-creatinine ratio UPCR greater than or equal to 1.5 gram per gram. This medication is available as tablets. The strength is 0.75 milligram. Recommended dosing for this medication 0.75 milligram orally once daily with or without food. This medication carries a US box warning, embryo fetal toxicity. Based on animal reproduction studies, this medication may cause major birth defects if taken during pregnancy. If we look at the drug chemistry, this is a small molecule. This drug molecule contains a pyridine ring in the middle heterocyclic ring system, and then there are 3 carbon centers within the drug molecule with 2R, 3R, and 4S stereochemistry. In addition, this drug molecule contains a carboxylic acid structural motif along with the benzyl dioxazole heterocyclic ring system. The molecular weight for this medication 510.6 gram per mole. Hydrogen bond acceptor 8. Hydrogen bond acceptor refers to the number of oxygen and nitrogen within the drug molecule. Hydrogen bond donor is 1. Hydrogen bond donor refers to the number of hydroxy and NH groups within the drug molecule. Log P 5.79. The more lipophilic, the higher log P. So therefore, this log P is over 5. This is pretty lipophilic drug molecule. Polar surface area 89 square angstrom. This medication is available as a salt form, hydrochloride as a salt form. Mechanistically, this medication works as a potent and selective endothelin ETA receptor antagonist. This endothelin 1 is a very potent vasoconstrictor. It's thought to contribute to pathogenesis of immunoglobulin A nephropathy. So therefore, by blocking this ETA receptor, and so this would lowering the glomerular damage and reduce proteinuria. Again, this is a small molecule. It's potent. It's 34 picomolar, the binding affinity for the receptor. And also, this is very selective. It's 1800-fold more selective relative to ETB receptor subtype. Pharmacokinetically, the Tmax is about 30 minutes, 0.5 hour. Volume of distribution at steady states, 1,180 liter. Protein binding, over 99%. Metabolism by CYP3A enzyme, as well as UGT. UGT, that's the uridine 5' diphosphoglucuranosyl transferase. Half-life, 24 to 41 hours. Excretion in the urine, less than 4% as metabolites. In the feces, 86%, but 5.5% as parent drug molecule. Drug-drug interactions. Given this drug molecule is metabolized by CYP3A enzyme, so therefore, if we look at the strong or moderate CYP3A inducers, if they take these two medications together, inducer and atrasentan, so this would lower the drug exposure for atrasentan. So therefore, avoid concomitant use. In addition, for OATP 1B1, 1B3, that's organic A9 transporting polypeptides 1B1, 1B3 inhibitors, avoid concomitant use as well. The reason for that, because atrasentan is OATP 1B1, 1B3 substrate. Therefore, for patients, if they take atrasentan with OATP 1B1, 1B3 inhibitors, this would increase the drug exposure for atrasentan. So this can lead to unwanted side effects. Contraindications: pregnancy, hypersensitivity, adverse effects greater than or equal to 5%, peripheral edema, and anemia. PENPULIMAB. This medication was approved by the US FDA on April 23, 2025, and indicated in combination with either cisplatin or carboplatin and gemcitabine for the first-line treatment for adults with recurrent or metastatic non-keratinizing nasopharyngeal carcinoma, NPC, as a single agent for treating metastatic non-keratinizing NPC with disease progression on or after platinum-based chemotherapy and at least one other prior line of therapy. This medication, if we look at the dosage forms, it's available as 100 mg per 10 milliliter solution in a single dose vial. It's given by RV injection. Recommended dosage: combination therapy, 200 mg RV infusion over 60 minutes every 3 weeks. For single agent therapy, 200 mg RV infusion every 2 weeks. As you can see, this is a monoclonal antibody. The molecular weight is about 150 kilodalton. Therefore, compared to small molecule, this is a monoclonal antibody, larger macromolecule protein. So therefore, the unopened vials need to be stored refrigerated 2 to 8 Celsius, 36 to 46 Fahrenheit. Do not freeze. Do not shake. Mechanistically, This medication works as a programmed death receptor 1 PD-1 blocking antibody. This will increase the T cell proliferation and cytokine production, increase anti-tumor immune response, therefore lowering the tumor growth. Pharmacokinetically, volume of distribution 10 liter, half-life 32 days, metabolism. This monoclonal antibody will be metabolized into small peptides and amino acid via catabolism. Adverse effects greater than or equal to 20%. In the case of combination therapy, nausea, vomiting, hypothyroidism, constipation, decreased appetite, decreased weight, cough, COVID-19 infection, fatigue, rash, and pyrexia, that's increased body temperature and fever. In the case of single agent therapy, anemia and hypothyroidism. Currently, there's no contraindications listed on the prescribing information. Nipocalimab, brand name IMAAVY. This medication was approved by the US FDA on April 29, 2025, and indicated to treat generalized myasthenia gravis in adults and pediatric patients aged 12 years and older with positive anti-acetylcholine receptor AChR or anti-musclespecific tyrosine kinase MuSK antibody. This medication, the dosage forms is available 300 mg per 1.62 ml or 1,200 mg per 6.5 milliliter in a single-dosed vial. This is a monoclonal antibody ending with MAB, so it's given by IV injection. Recommended dosing for this medication is based on weights, patient weight-based dosing. Initial dose 30 mg per kilogram IV infusion over at least 30 minutes. After 2 weeks, the maintenance dosing is 15 mg per kilogram IV infusion over at least 15 minutes every 2 weeks. Again, as mentioned, this is a monoclonal antibody, biologics. Therefore, the vial, the unopened vial, needed to be stored refrigerated 2 to 8 Celsius, which is 36 to 46 Fahrenheit. Do not freeze, do not shake. Mechanistically, this human IgG1 antibody works as a neonatal Fc receptor, FcRn blocker. This will lower circulating IgG levels, including the harmful IgG autoantibodies, one of the root causes for gMG. Pharmacokinetically, volume of distribution 2.67 liter, half-life 29.3 hours, metabolism into small peptides and amino acid via catabolism. Drug-drug interactions. Monitor closely for reduced effectiveness of medications that bind to human FcRn. If needed, consider discontinuing IMAAVY and use alternative therapy. Contraindications. Patients with a history of serious hypersensitivity reaction to IMAAVY, or any gradients within the drug products. Adverse effects greater than or equal to 10%, respiratory tract infections, peripheral edema, and muscle spasm. Avutometinib, defactinib, brand name AVMAPKI FAKZYNJA Co-Pack. This combination medication products was approved by the US FDA on May 8, 2025, and indicated to treat KRAS-mutated recurrent low-grade serous ovarian cancer, LGSOC, in adult patients who have received prior systemic therapy. This combination therapy product contains two medication products. One, AVMAPKI, is available as a 0.8 mg capsule. FAKZYNJA is available as 200 mg tablets. For recommended dosage, avutometinib 3.2 mg, which is 4 capsules, taken orally twice weekly on day 1 and day 4. For defactinib, 200 mg, which is 1 tablet, taken orally twice daily for the first 3 weeks of each 4-week cycle, which means for this recommended dosage therapy regimen, so you can see patients are on this combination therapy for 3 weeks and then off for 1 week. This dosing regimen would help mitigate the adverse effects for this combination products, in particular related to MEK inhibitor. This combination therapy product contains 2 drug molecules. For avutometinib, it's a small molecule, molecular weight 471.46 grams per mole, hydrogen bond acceptor 10. Hydrogen bond acceptor refers to the number of oxygen and nitrogens within the drug molecule. Hydrogen bond donor 2. Hydrogen bond donor refers to the number of hydroxy and NH groups within the drug molecule. Log P 1.34. Polar surface area 141 square angstrom. This drug molecule is an acidic drug molecule for this NH group because of the electron withdrawing effect from sulfur group as well as from the fluorine. So therefore this drug molecule is formulated as a potassium salt. So this would be deprotonated, negatively charged. So it's available as a potassium salt. For defactinib, molecular weight is 510.50 grams per mole. Hydrogen bond acceptor 11. Hydrogen bond donor 3. Log P negative 0.74. Polar surface area is 150 square angstrom. This drug molecule is available as hydrochloride salt form. Mechanistically, avutometinib ending with metinib, so this drug molecule indicating this is a member of MEK1 inhibitor class, works as a mitogen activated protein kinase 1 MEK1 inhibitor. For defactinib, is an inhibitor of focal adhesion kinase FAK and protein-rich tyrosine kinase 2 PIK2. Pharmacokinetically, for avutometinib, Tmax about 2 hours under fasted conditions. For defactinib, it's about 4 hours under fed conditions. half-life for avutometinib, 51 hours. So you can see very long half-life. For defactinib, half-life is about 9 hours. So therefore, these two medications, they have a very different half-life. So therefore, this is part of the reason. So you can see for avutometinib, it's taken twice weekly, but for defactinib, it's taking twice daily dosing because they have very different half-life profiles. So therefore, they need to take this combination products separately. So therefore, they cannot co-formulate this one as one combination product because of the very different pharmacokinetic profiles. Protein binding for avutometinib, 99%. For defactinib, about 90%. Volume of distribution at the steady state for avutometinib, 25 liter. For defactinib, 1,560 liter. Metabolism, so you can see both medication, they are the subject for CYP3A4. In addition, for defactinib is also subject for CYP2C9. Excretion profiles in the urine for avutometinib, 52%, but 3.2% as the parent drug molecule. In the feces, 39%, but 9.2% as a parent drug molecule. For defactinib, in the urine, 7.6%, but 0.8% as a parent drug molecule. In the feces, 87%, with 52% as a parent drug molecule. As mentioned, given both medication, they are subject for CYP3A4. So therefore, with regard to drug-drug interactions, for example, strong and moderate CYP3A inhibitors, for example, the azole and fungal agents like itraconazole. So this would increase the drug exposure for both medication products. So this would increase the risk of the adverse effects. So therefore, in this case, would avoid concomitant use. Similarly, for patients, if they take strong and moderate CYP3A inducers, for example, phenytoin, in this case, the inducers would make the medication metabolize much faster. So this would lower the drug exposure for this combination product. So therefore, this can lead to decreased efficacy. Therefore, in both cases, strong and moderate CYP3A inhibitors or inducers need to avoid concomitant use. For patients, if they take some other, for example, anticoagulants, warfarin, this would increase the drug exposure for warfarin. So therefore, this can lead to increased risk of bleeding. Avoid concomitant use. If unavoidable, so make sure monitor RNR for warfarin closely. For patients, if they also take gastric acid reducing agents, for example, PPI, proton pump inhibitor, or H2 blockers, because the gastric acid reducing agent, this would increase the pH value, and this would decrease the absorption or solubility for defactinib. So therefore, require avoid concomitant use. If unavoidable, so make sure take this medication products FAKZYNJA 2 hours before or 2 hours after the gastric acid reducing agent. For adverse effects, at least 25%, nausea, fatigue, rash, diarrhea, musculoskeletal pain, edema, vomiting, abdominal pain, dyspepsia, dermatitis, acneiform, vitreoretinal disorders, stomatitis, that's the inflammation of the mouth, pruritus, visual impairment, constipation, dry skin, dyspnea, cough, urinary tract infections. Trastuzumab, vedotin, brand name Amrelis. This medication was approved by the US FDA on May 14, 2025, and indicated to treat adult patients with locally advanced or metastatic non-squamous non-small cell lung cancer with high c-MET protein overexpression for patients who had prior systemic therapy. This medication is available as a 20 mg or 100 mg as a lyophilized powder for RV intravenous use. Recommended dosage, so you can see in this case, it's based on the patient's body weight, weight-based dosing, 1.9 mg per kilogram, RV infusion, over 30 minutes every 2 weeks. As you can see, based on this drug molecule, this is a member of ADC drug class, antibody drug conjugate. You can see this medication contains this MAB along with the drug payload MMAE. So that's the small molecule payload MMAE. So that's the microtubule receptor inhibitor, along with the linker and the spacer in between. Given this medication product contains a monoclonal antibody, so therefore the drug product need to be stored refrigerated 2 to 8 Celsius. Mechanistically, this c-MET directed antibody drug conjugate binds to the c-MET cell surface receptor for hepatocytes growth factor. But in general, for this class, ADC drug class, antibody drug conjugates, they bind with the receptor, overexpress the receptor on the cancer cells. Once bound with the receptor, in this case, the c-MET, and then the drug complex will be internalized within the cancer cells, and later on the small molecule will be released. Microtubule inhibitor, MMAE. So that's the monomethyl auristatin E drug molecule. So that's a microtubule inhibitor. Why this protein-lytic cleavage? So therefore, releasing this small cytotoxic MMAE payload small molecule, this would lead to the cell cycle arrest and apoptosis, programmed cell death. Pharmacokinetically, volume of distribution 3.4 liter, half-life 3 days for this ADC compound complex, like antibody drug conjugate, but 4 days for this unconjugated small molecule payload, MMAE. Protein binding based on in vitro studies ranging from 68 to 82%. Metabolism. This medication product is metabolized, expected into small peptides and amino acid and unconjugated MMAE small molecule, so once cleaved from the antibody complex. In addition, this small molecule MMAE is a subject for CYP3A4 enzyme. Another thing I want to mention, this ADC drug conjugate So you can see there's a 3, so that's referred to drug antibody ratio, which means one antibody is attached to approximately 3 small molecule like MMAE payload. As mentioned, this MMAE is a subject for CYP3/4, so therefore with regard to drug-drug interactions, strong CYP3A inhibitors, this would lead to increased drug exposure for MMAE payload because the drug molecule will be metabolized slowly. So therefore, concomitant use may increase the exposure to unconjugated MMAE. So in a similar context for CYP3A inducers, so this can lead to decreased exposure to unconjugated MMAE. For adverse effects, at least 20% peripheral neuropathy, fatigue, decreased appetite, peripheral edema. Ecotrimo, the brand name TRYPTYR. This medication was approved by the US FDA on May 28, 2025, and indicated for the treatment of the signs and symptoms of dry eye disease. This is a small molecule with lipophilic 2-isopropyl 5-methylcyclohexane. So basically this is a lipophilic motif with the carboxamide linker spacer in the middle and 4-methoxyphenol motifs. Molecular weight for this medication 289.42 gram per mole, 100 bound acceptor 3, 100 bound donor 1, log P 5.02. So you can see in this case log P is over 5. So therefore this is a pretty lipophilic drug molecule. Polar surface area 38 square angstrom. Mechanistically, this medication is considered the first-in-class neuromodulator for treating the dry eye disease. It's an eye drop. So therefore you can see the recommended dosage: instill 1 drop in each eye twice daily, approximately 12 hours apart. Again, this is a topical eye drop. It's available as 0.003% of formic solution. So mechanistically, this is considered the first neuromodulator eye drop for treating dry eye disease. Works as a transit receptor potential metastatin 8, that's a TRPM8 thermoreceptor agonist. This would lead to trigeminal nerve signaling and increase the basal tear production. Although the exact mechanism of action related to dry eye disease is unclear with regard to pharmacokinetic profiles. And so given this topical or ocular dosing, the drug exposure in plasma is minimal. So therefore, for drug-drug interactions, no clinically significant drug interactions are expected. Adverse effects in stimulation side pain, so that's about 50% patient population experience this installation side pain. Clasiruvimab, brand name Influenza. This medication was approved by the US FDA on June 9, 2025, and indicated for the prevention of respiratory syncytial virus, RSV, lower respiratory tract disease in neonates and infants who are born entering their first RSV season. Chemically, it's a fully recombinant human immunoglobulin G1 kappa monoclonal antibody. The molecular weight for this medication is about 149 kilodalton. The dosage form. This medication is available as 105 mg per 0.7 milliliter in a single-dose prefilled syringe for intramuscular injection. For recommended dosage, it's 105 mg administered as a single intramuscular RM injection. Given this medication product is a monoclonal antibody, as you can see based on the suffix of the drug name, monoclonal antibody. So therefore, this medication needed to be stored in a refrigerator ranging from 2 to 8 Celsius, which is 36 to 46 Fahrenheit. In addition, this is a protein product, monoclonal antibody, so therefore make sure do not freeze medication product and also do not shake the medication product as well. Mechanistically, it works as a respiratory syncytial virus RSV F protein-directed fusion inhibitor. Therefore, this would prevent fusion of viral and cellular membranes and viral entry. Pharmacokinetically, Tmax, that's the time to reach the maximal plasma concentration, 6.5 days. Half-life is about 44 days, so therefore this is a very long, long-acting monoclonal antibody. Volume of distribution is 830 milliliter for a typical infant weighing 5 kg. Metabolism. This protein will be metabolized into smaller peptides, while catabolism. Contraindications. Infants with a history of serious hypersensitivity reactions, for example, anaphylaxis to any component of influenza. Adverse effect. Injection sites erythema, that's the injection site's redness. 3.7% of patients. Injection site swelling, 2.7% of patients. Rash, 2.3% of patients population. TRYPTYR, brand name Itoposide. This medication was approved by the US FDA on June 11, 2025. And indicated for the treatment for adult patients with locally advanced or metastatic ROS1 positive non-small cell lung cancer. Chemically, it's a small molecule with imidazole and pyridazine hexacyclic motif, along with imine, secondary imine, and primary imine functionality. It's available as a 200 mg capsule. Recommended dosage 600 mg, which is 3 capsules, taken orally once daily on an empty stomach. No food intake at least 2 hours before and 2 hours after taking Itoposide. This is a small molecule. The molecule weight is 405.48 gram per mole. Hydrogen bond acceptor 6. Hydrogen bond acceptor refers to the number of nitrogen and oxygens within the molecule. Hydrogen bond donor 3. Hydrogen bond donor refers to the number of NH or OH hydroxy groups within the drug molecule. Log P 2.67, polar surface area 77 square angstrom. Given the drug molecule contains 2 imine functionality, secondary imine and primary imine, so therefore this medication is available as the salt form with the adipic acid. So this is TRYPTYR adipate with the salt form. Mechanistically, it works as an inhibitor of tyrosine kinase ROS1 as well as tropomyosin receptor kinase. So for this mutation, the ROS1, the fusion protein And so this is accounts for about 1 to 2% the lung cancer patient population. So therefore, this is a rare type of lung cancer. Pharmacokinetically, Tmax, that's the time to reach the maximal plasma concentration, 2 to 6 hours. Volume of distribution is very large, 9,820 liters. Protein binding ranging from 93 to 96%. Metabolism is mainly metabolized by CYP3A enzyme along with CYP2C8, CYP2C9, and 9 CYP450 enzymes. So for example, sulfation and acetylation with the immune functionality. Half-life 66 hours. So therefore, this molecule has a very long half-life. So therefore, this medication is taken once daily dosing. Excretion in the urine, 11%, but 2.9% as a parent drug molecule. In the feces, 75%, but 15% as parent drug molecule. Drug-drug interactions. As mentioned, this medication is a substrate for CYP3A. So therefore, for patients, if they also take some other strong or moderate CYP3A inhibitors, for example, the azole antifungal agents like itraconazole, or the CYP3A inducers, for example, rifampin, that's the anti-tuberculosis medication. In the case of strong or moderate CYP3 inhibitors, this would increase the drug's exposure for taletrectinib. In the case of strong or moderate CYP3 inducers, this would lower the drug exposure for taletrectinib, so therefore can have the risk of either increase the adverse effects or have the risk decrease the effectiveness of the medication. So therefore, in both cases, need to avoid concomitant use. In addition, taletrectinib prolongs the QTC interval. So therefore, if patients also take some other medication which prolongs the QTC interval, for example, the antiarrhythmic agent, this need to avoid concomitant use. Try to minimize the risk for prolonging the QTC interval. Finally, for patients, if they take some other gastric acid reducing agents, for example, the proton pump inhibitors, PPI, and H2 blockers, avoid concomitant use. If unavoidable, make sure the patients take Ituzi 2 hours before or 2 hours after the patients take the locally acting antiacid. For adverse effects greater than or equal to 20%, diarrhea, nausea, vomiting, dizziness, rash, constipation, fatigue. Garadacimab, brand name, and Dimbre. This medication was approved by the US FDA on June 16, 2025, and indicated for prophylaxis to prevent attacks of hereditary angioedema, HAE, in adults and pediatric patients aged 12 years and older. The dosage forms for this medication is available as 200 mg per 1.2 milliliter solution in single-dose pre-filled auto-injector or in single-dose pre-filled syringe with needle safety device. It's given subcutaneously. Recommended dosage: initial loading dose 400 mg, which is 200 mg subcutaneous injections, followed by maintenance dose 200 mg subcutaneous injection once monthly. This medication is a monoclonal antibody ending with the MAB. The molecule weight for this medication is about 148 kilodalton. Given this is a monoclonal antibody, it needs to be stored in a refrigerator 2 to 8 Celsius, 36 to 46 Fahrenheit. Do not shake, do not freeze the medication. Mechanistically, this human RGT4 lambda light chain monoclonal antibody works as an activated factor XIIa inhibitor. This would block the activation of prekallikrein to kallikrein and production of bradykinin. Bradykinin is associated with inflammation and swelling of HAE attack. Therefore, this would block the cascade pathway leading to a HAE attack. Pharmacokinetically, Tmax, that's the time to reach maximal plasma concentration, about 6 days. Bioavailability, 39%. Volume of distribution, 11.8 liter. Half-life, 17.4 days. Metabolism is expected into small peptides, while catabolism. Again, if we look at the half-life, about 17.4 days. So therefore, you can see long half-life is giving once monthly dosing. Drug-drug interactions. With regard to drug interference with laboratory tests, Andembry can prolong activated partial thromboplastin time, APTT, due to an interaction of garadacimab with the APTT assay. Currently, there is no contraindications listed on the prescribing information document. Adverse effects greater than or equal to 7%, nasopharyngitis, abdominal pain. Here are all the key references which I have used to prepare for today's video. FDA Novel Drug Approval for 2025 is a very valuable resource. Pretty much all the information which are shared today are based on their respective prescribing information documents, which are available at the US FDA websites, along with the manufacturer drug websites. All the physiochemical properties are based on chemistbyler.com. Finally, I want to thank you all so much for watching. If you enjoyed the video, please consider subscribing for future medication video updates. As always, keep learning and elevating. Thank you so much.